So good afternoon, everybody. We are taking today this interview from the UROONCO Bladder Cancer Platform. I'm Francesco Del Giudice, one of the associate editor, and I will be very glad to introduce today Professor Masson-Lecomte from France, in Paris, who has been leading and sharing the session on oligometastatic bladder cancer that was held on Friday at EAU 2024. And so welcome, and why don't we get directly to the point on the interview? So why are we arrived to talk about oligometastatic bladder cancer just in 2024, and why this session has never happened before at the EAU?
Yeah, well, thank you very much for having me and for saying my name properly.
Yeah, that was hard.
Actually, this is one of the first time a topic about oligometastatic disease has been discussed, to my knowledge, in one of the congresses. I think it's very important to remind everyone that we do not have high-level evidence about the prognostic significance of tumor burden in bladder cancer, as we have, for example, with prostate cancer, where we know that the volume of the disease is extremely important in the treatment decision. So since we don't have high-level evidence, but we are in an era of extraordinary breakthrough on a systemic treatment point of view for metastatic tumors, there was a few years ago a consensus meeting between the EAU, the ESMO and the ESTRO, where leading experts revised this topic and produced a definition of what oligometastatic disease is in order to be able to build some clinical research in that area. And so the definition that came out was it was a bladder cancer metastatic with up to 3 metastatic sites. But it's very important to say that this requires some clinical validation. We do not really know how relevant it is for the patients.
Well, this is once again a great point. I think that after having attended the section on Friday, what was very, very much impactful was about the translational approach that nowadays we need in order to assess this kind of disease. So starting a little bit and try to go back through the session itself, one of the key points I would say at this point, and we have learned this lesson from prostate cancer and kidney cancer as well, would be the proper technology imaging at this point to eventually assess those that would you say oligo versus rather than oligometastatic. So would you like to summarize a few point aspects of the session?
Yeah, I would say that regarding imaging, there are 2 points. There are the point about initial assessment of the disease, and then there is the point about assessment of the response. So regarding the initial assessment of the disease, of the metastatic disease, obviously the whole question is about how to use TEP-CT, because the recommendations rely on classical CT scan, but more and more of us in daily clinical practice are using TEP-CT. It's going to be easy. There is no answer in that regard. Right. So the definition based on the consensus is an oligometastatic disease based on classical CT scan. But what is true is that when you see 3 metastases on CT scan, it is more than likely that if you do a TEP-CT, or even if you don't do a TEP-CT, there will be some micrometastatic disease that you cannot see. So this still requires definition. It's unknown, it has to be explored. The second point that is very important, and Valeria Panebianco spent some time on it, is about the assessment of response. So the 2 messages are, regarding the assessment of local response, which is going to be important in these oligometastatic patients, clearly the MRI is going to be the tool, the major tool with the NAC virus that is being developed. So perform MRI and look at the response using MRI in the bladder. Regarding the metastatic disease, the main message is use whatever you use, but use the same tool to assess the response. So if you defined your metastatic disease based on TEP-CT at the initiation of treatment, use TEP-CT. If it was liver MRI at the beginning, use a liver MRI to make sure that it's comparable and use the same imaging technique.
Okay, well, that was a nice reply. Why I like to move a little bit forward right now to what we have been probably in the past year as bladder cancer specialists a little bit more aware about. So the benefit of a systemic treatment in most of the cases is in a neoadjuvant setting, which is something that we would like probably to address to any patient that we would define oligometastasis before thinking about taking care of local treatment. And about this regarding point, how do you think going in terms of assessing this patient, eventually addressing them later to radical cystectomy? Are we talking about the classic neoadjuvant chemo? Would you rely on the VESPER trial data? Or eventually, what is point of concern in this oligometastatic setting?
So this is a very important semantic point. You're using the word neoadjuvant,
Correct.
which could be considered as controversial in the setting of a metastatic disease. So I would more use the induction therapy because I don't want urologists to come out with the idea that all these patients are going to be treated surgically after the treatment, because it's all going to be a question of response. So this is an induction treatment that is going to rely on cisplatin-based chemotherapy, if possible, or platinum-based chemotherapy, probably different therapies in the future with the EV-Pimbro, but whatever first-line therapy is recommended is going to be the first-line treatment. And it's extremely important to say that systemic therapy has to be the first-line treatment, even in oligometastatic disease. And then the main message, and Fred Widges that was chairing with me summarized it very well at the end of the session, is that it's all a question of response. So you are going to consider either local and metastasis-directed therapies in the patients that are good responders to first-line treatment. If your patient is not a responder, he's going to go to second line. The fact that he's oligometastatic is not going to make any difference if he had 5 metastatic sites. So if he's a good responder, then you have 2 things to consider. First is to locally treat the patient. And there, the question of cystectomy versus radiotherapy is kind of the same that you would have for a localized patient.
Exactly.
Young or older, comorbidities, patient shared decision making, how the bladder works, etc. So, and both can be considered. If you are doing a cystectomy, it's with lymph node dissection. If you're doing radiotherapy, it's probably with pelvic nodes. And regarding metastasis-directed therapy, there it's a field where we have absolutely no evidence, so I cannot give a clear message about that. It's feasible. Usually it's stereotactic radiotherapy. It could be, in some cases, be surgery, but it really has to be discussed on a case-by-case basis or in a multidisciplinary tumor board.
Of course. And yes, let me come back from my semantic original mistake. And I would like to say, yes, probably this is once again an interview for most, I would say, urologic platform-based audience. The role and the difficulties of this kind of surgery, considering radical cystectomy as the primary treatment to eventually play around. I mean, there are some data right now from 3 modality therapy treatments that we are coming back, that also radiotherapy to the bladder is associated later with, complication, poor survival, and etc. So where would eventually you think we are going to move in terms of the decision for the primary therapy in this kind of oligometastatic setting?
Well, again, I think it's really a shared decision with the patient. It's not black and white at all. So the cystectomy can be difficult in those patients, particularly if they have locally advanced disease. The radiotherapy also comes with a burden of potential complications. So I cannot make a clear message about that. It's really a case by case. It was really, really interesting. We really discussed about the age of the patient. If he's 50 years old, is it going to be difficult than if he's 80 years old? And it was really nice to see that the experts did not agree. Some would consider that the young patient would be a very good candidate for bladder preservation, while others said the contrary. So it's all a matter of taking globally the patients, the potential urinary symptoms that he has, the burden of the disease after the chemotherapy, and deciding with him.
Well, beautiful. So as a conclusion, I would say that we are truly at the beginning of something that might potentially give us our first feedback in the next really 5-10 days, probably. And hopefully all of these would be eventually moved in the setting of clinical trials. And we will have clear messages eventually as soon as possible. But who knows if this is going to be a new frontiers for urologists and primary care of bladder cancer therapy as well. So let me thank you once again for your time, patience, and collaboration with our UROONCO Bladder platform. I don't know if you want to make any remarks on conclusions, but otherwise we are happy with that.
Thank you very much for having me. It was a
Beautiful.
pleasure.
Thank you so much.